This is Brian Wormers recording Respiratory Dysfunction, part 2 out of 3, and we're going to start in with infectious etiologies. So, in the pediatric realm, when we talk about respiratory, a lot of it is infectious etiologies. Things that you've heard of probably are RSV, influenza, parainfluenza, human metapneumovirus, enteroviruses, group A strep. So all these things are very common in kids. So these are all the infections that can cause these things. Oftentimes we call things by what area they infect. So nasopharyngitis, pharyngitis, tonsillitis, mononucleosis, acute laryngitis, laryngeal tracheal bronchitis, spasmodic croup, tracheitis, and we can kind of see that we're going lower and lower into those different fields. So influenza and RSV can infect lots of these different areas. Commonly what we talk about in kids is the bronchiolitis part. And so that's going to be your RSV, your influenza, human metapneumovirus, and those type of things. So you can take a look at each one of these. They've got good links here. The one thing I do want to share with you is that if you really look at all of these, for the most part, we treat them all with symptomatic care, and we'll talk about that in a little bit. The one exception would be using Tamiflu for an influenza, and we can talk about, some preventative methods. So talking about Synagis for your RSV, and some of your immunizations can help with some of these other ones. The one that is a little different than this one is your Group A strep, or GAS is what it's sometimes abbreviated as. This is strep throat, and this is very common in children. This is something you can treat with antibiotics. We usually treat it not because of the sore throat, but we treat it because of the systemic side effects that this can have and the different places that this can go. One of the big things that we'll talk about in cardiac is that it can cause rheumatic fever and impact on those cardiac valves, often needing surgery to replace the valves. Otherwise, it can go down to the kidneys, and you can get post-strep glomerular nephritis. And that's the main reason why we treat Group A strep. It's not for the sore throat, but it's for the fact that it can go into the heart and it can go into the kidneys. So the theory behind it is that your body has the antigens of this Group A strep, and these little antigens will get seeded into these highly vascular places. Your body is ramped up, and it starts attacking the cells that have got these antigens in it. Even though that this is displaced and these are not functioning, your body is just revved up, gets too aggressive, and causes harm to your body in an autoimmune type of reaction. So as I said before, oftentimes we look at where these things are and call it that. So we call it a tonsillitis, we call it tracheitis, we call it a bronchiolitis, and any of these can cause that technically. Trying to think on this one. The only other thing is enteroviruses. Often they cause the kids to be extremely crabby and they spike a big fever. But a lot of these all kind of look the same. And without testing, you'd probably not be able to define and tell a kid that was RSV from parainfluenza from a human metapneumovirus. There are some great examples here of the croup. So this little kiddo has got a severe cough. With croup, some of the mainstays of treatment would be to have them in a cold environment. So oftentimes these kids are sick at home. Parents bring them into the emergency department in the wintertime, take them outside in the cold air. That cold air relaxes and decreases some of the swelling in the airway. And by the time they get to the emergency department, they're actually acting better. Another treatment for croup would be putting them in a warm shower or place where you can get some steam, and that's been proven to help out as well. In severe cases with croup, we can talk about adding steroids, but there can be paroxysmal swelling and complications with that and a rebound side effects of that. Some things that are maybe more serious would be bacterial tracheitis. This is an emergency. If you have a child that is hunched over in that tripoding position, having difficulty in breathing, and having lots of oral secretions, this kid needs further evaluation in the operating room in case of this. This is not one of those kids where you're going to go and assess the child. You're going to let them be in a position of comfort, often near mom and dad or on mom and dad's lap. And you do not want to be looking in their mouth because you don't want to agitate them, because they can close off their airway with a tracheitis. Other things that you can see in the pediatric realm would be pertussis. This is a great picture of this. But often what we see with pertussis is it's coughing, gagging, and then even vomiting because of the coughing. This is a miserable thing that people can go through. Immunizations do help with this one, but some of the leading causes of this would be family members giving it to a child. So this can run its course. For treatment of pertussis, we can give azithromycin. This tends to shorten the course, though only, and doesn't necessarily make the signs and symptoms for that particular patient any better. Other things that you'll see would be tuberculosis, just like in the adult world. And remember, you need to have a PAPR or the N95 mask along with that one. And then some of the severe acute respiratory syndromes or Middle Eastern respiratory syndromes. These are some of the rare things that we're concerned about. It's like the avian flu and different things like that we're really afraid will morph and become highly virulent and spread amongst patients. So within this one, I want you guys to do all these, the crosswords, to kind of learn about comfort care and work with that. Decongestant cold medicine. There's a quick overview here. The long and short of it is don't use it in children. With decongestants, I don't prescribe it for any child under the age of 6. And for those children above 6, I'll only prescribe it at night to let them have a good night's sleep. The reason why is that it's been linked to increased morbidity and mortality. When these children are sleeping at night, they tend to decrease their level of consciousness to the point where they don't want to breathe, and that causes complications, of course. For those older kids that are older than 6, I only do it at sleep because during the day I want to have them cough and get the secretions out. So the short and sweet of decongestants and cold medicine use in kids is really don't do it. It's not recommended, and it can be very dangerous, especially for young kids. So otitis media. So why do we cover the ears when we're talking respiratory? Well, often we're looking at some of the same things that are causing upper respiratory infections that go up through those eustachian tubes and cause complications in the ears. So the 3 major things that can cause an otitis media would be strep pneumo, H. influenza, or M. catarrhalis. And so these things are some of the most common things that we have to treat, and so our treatments are going to be based upon those. Oftentimes, there is a big push right now to do less and less antibiotic treatments, and we'll cover that on future slides. But looking at this, so what you see on this ear, you can still see the bony prominences within the ear. You've got a pearl gray tympanic membrane. You can see the fluid underneath is nice and clear. And you've got your cone of light that points towards the jaw. So you're looking at a person's right eardrum, and it's intact. And it looks good, and this is healthy, and this is normal. On this ear, you are seeing that you've got some pus underneath here. It's reddened, it's irritated. You cannot see the bony prominences due to the swelling and the fluid behind there. The fluid to me looks infected, and you've even got some dimpling here. You do not have a cone of light that's reflected towards that jawline. To me, the cone of light looks like it's up here, and that's definitely not in the right area. This is not a skill commonly used by nurses, but I did want you to be aware of it. The fluid in the space can be or cannot be related to infection. It might just be serous fluid. We might call it an otitis media with effusion. But just realize that we don't treat every single otitis media that's got some fluid behind there. So what do we do with it? So we try to prevent acute otitis media as much as possible. We do that with immunizations. We do that with trying to promote breastfeeding. We try to avoid smoke and air pollution around these children. Avoid propping bottles near these children. And then also avoid having them lay flat while they're feeding. So some treatment for this with acute otitis media is watchful waiting. We'll cover that on the next slide. We also can see here that we've got PE tubes, pressure equalizing tubes, or they can do the tympanostomy. So the tympanostomy is basically just putting a hole in that tympanic membrane and allowing the fluid that's trapped behind there to drain out. You can see that there's different colors of tubes. I've seen white, blue, green. We usually try to avoid red because we want to see if there's any bleeding involved with this. But the colors, to my knowledge, don't mean any particular thing for sizes or anything like that. We can treat with ibuprofen. Sometimes that eustachian tube is swollen and the fluid gets trapped in the middle ear. And so by opening up that eustachian tube with decreasing their swelling, sometimes that will help with the fluid behind there and the pain and discomfort that's caused by that. If it is a severe ear, like we saw on that previous page, we can use oral antibiotics to treat it. We are looking at some of the newer treatments, so we can put eardrops through these tympanostomy tubes. We can do injectable treatments, so take a needle and a syringe and go through that tympanic membrane and do it that way. There's also some impregnated paper that you can combine this with and have it transcutaneously absorbed through that membrane. So they are looking at new treatment methods for otitis media. One of the most difficult things about otitis media is, of course, not those two that you saw on the previous slide, because those are pretty self-explanatory, but there's a gradient in between there. And when you start talking to different providers, some of them will treat things differently depending on how they view the ear. So one of the big things we can do would be watchful waiting. So here's a nice review and a nice summary of it for you. But basically what it's saying is that if the child is fairly stable, they don't have a lot of pain, they are over the age of 2, what we can do is just say, let's watch this. Sometimes we'll see acute otitis media in patients that really don't have much pain. They'll be in for a well child check. We'll see the ear is red and it's got some swelling, but it doesn't seem to be bothering the child at all. And that would be a great case if that kid was over the age of 2 to wait and to see how they respond to this. And if the situation changes, if they get worse, then prescribe antibiotics at that point in time. Many of the otitis medias are related to viral infections, and thus the antibiotics really will not do much for this. And then we have to worry about the cost as well as the complications that antibiotics can cause. This will conclude part 2 of respiratory dysfunction. Part 3 will continue on slide 12.